Well, welcome everyone. It's time for the EKG case for the week of April 15th, 2012. Got a great one for you this week. It's kind of a tough one, but if you're careful and you look closely, you're going to make the diagnosis here. So this is a 50-year-old man that presents to the emergency department, not quite obtunded. He was a little lethargic, extremely somnolent, and our usual initial management of dextrose and Narcan, and then repeat Narcan, and then repeat Narcan didn't work. So this guy has something else going on. We got a quick 12-lead EKG because we noticed that when he was triaged, his vital signs were notable for significant bradycardia, and his blood pressure was hanging around maybe systolic of about 100. So borderline blood pressure. And here was the 12-lead EKG. Now the computer was reading this as a junctional rhythm and maybe just a non-specific interventricular conduction delay because the QRS complexes are just a little bit wide. It's fairly non-significant or non-specific, I should say. There's a lot of artifact up here and what looks like a little artifact up there, and I'm not really sure what to do with that. He wasn't shivering, he wasn't hypothermic, so for whatever reason in lead V1 it wasn't picking up really well. And so everyone's looking at this and calling it a junctional rhythm, but you've got to be very careful. One of the things that I was taught by Edward Chung, who was a really smart cardiologist who taught me a lot about EKGs back when I was in residency, was that you need to look everywhere. When you're not seeing what you expect, when you're not seeing QRS complexes, when you're not seeing P waves, whatever it is that you're looking for, when you don't see it, before you say it's not there, you've got to look everywhere. Be very careful. Look everywhere. Now, when you're calling this a junctional rhythm, what you're essentially saying is that you don't see clear-cut P waves. So Dr. Chung would say you've got to look everywhere. Now, when you do start looking everywhere, maybe you start appreciating just a really little subtlety in some of these leads. There's a little blip right there, and I don't know if that's anything right there. A little blip right there, a little blip right there, a little blip right there, and then if you move along, you see some of these, excuse me, some of these other things as well. Is that anything of significance, or is it just artifact? Well, a lot of times we see things on the 12-lead EKG that we just kind of blow off as being artifact. But before you call something artifact, you've always got to consider the possibility that it's not artifact and maybe it's actually a little P wave. How do you know? Is this just artifact or is it truly a P wave? Well, what you do is you get your calipers out and you just map it out. So there's my calipers, these little red arrows, and I'm just going to move these across the EKG. And if those little blips do map out, you can't call it artifact. It's got to be something real. So let's move this across, and sure enough, those little blips are mapping out. And so what we're looking at, actually, these are actually P waves. They're very small P waves, but they are definitely P waves. It's not artifact. You know that it's not artifact because it's mapping out. It would be too much coincidence for artifact to map out like this. So essentially, what this is it's some type of an AV block. Now, how do you tell what type of AV block it is? Obviously, it's not first-degree AV block. If this were Mobitz 1, also known as Wenckebach, also known as second-degree AV block type 1, what you notice is that the PR interval, everywhere there's a PR segment, would be getting longer, all right? And if this were Mobitz 2, the PR segment ought to be, there's another PR right there. And if this were Mobitz 2, the PR segment ought to be completely stable and unchanging. And if, on the other hand, this is third-degree block, the PR segment should be randomly changing. And so if you just look at the PR segments that we've noted up here, you notice that the PR segment is relatively long, then it gets pretty short, then a little bit longer and a little bit longer, but there's no real clear-cut pattern to it. If you look at some of these other PR intervals as well, you really notice that there's no good pattern to this at all. And what that means is that this is actually complete heart block. This is third-degree heart block with some type of escape rhythm, and the QRS is just a little bit wide, but not wide enough that we would call this a ventricular escape. So this is complete heart block with maybe a junctional escape rhythm. So what you're going to do with this patient, you might consider maybe this is an overdose of calcium channel blocker, beta blocker, DIG, maybe there's some narcotics on board, probably not since he didn't respond at all to the Narcan, but there's a number of different things that can give you bradycardia, right? So real quick, let's just go back through that list. Calcium channel blockers, beta blockers, digoxin, opiates, cholinergics, and pesticides, things like that can give you bradycardia. But one of the common causes of bradycardia in emergency medicine that is not typically taught in ACLS and sometimes even gets overlooked in toxicology conferences is the possibility of hyperkalemia. Always, always, one more time, always think of hyperkalemia when you've got a patient with a significant bradycardia or weird AV blocks. And when you think about that, maybe now you start noticing that there's just a little bit of peaking of some of the T waves. It's not tremendous. And by the way, didn't we also say that the QRS is just a little bit wide? Hyperkalemia does that as well. And by the way, hyperkalemia also makes the P waves get smaller and smaller until they virtually disappear. So there's a bunch of things on this 12 lead EKG which are strongly suggesting hyperkalemia. So this patient was given calcium and given some bicarb, and sure enough, he responded. And then a little while later, we got a potassium level back, and it was 8.5. You recall normal level is 3.5 up to 5, so this was considerably elevated hyperkalemia. All right, so again, just a couple of simple take-home points from this particular case. Number one, when you don't see P waves, before you call it a junctional rhythm or a ventricular escape rhythm, look everywhere. And if you think you're looking at some artifact, before you call something artifact, get your calipers and map it out. And if it maps out, it's not artifact. Those are actually P waves that are just very small. They're hidden, they're subtle, whatever the case may be. And then the second key point, and we've talked about this before in this EKG videocast series, please remember that hyperkalemia is a common cause in emergency medicine of hyperkalemia. Maybe they don't see this up on the wards too often because we've already treated it, but in the emergency department, undifferentiated bradycardic patients showing up in the emergency department, you've got to think about hyperkalemia. And when in doubt, just go ahead and give the patient a little calcium, a little bicarbonate, especially that calcium, and suddenly what ends up happening, the P waves get bigger, they reappear, and the patient's heart rate gets slower, or rather, the heart rate picks back up, and the QRS narrows down, and voila, you've got your diagnosis. So, hope that case was fun and helpful, and I will talk to you next week. Take care.